Доброго вечора, українські радіаційні онкологи, медичні фізики, радіологи, медичні онкологи. Слава Україні! Дуже дякуємо, що приєдналися до Research Methodology Course for Ukraine. My name is Natalia Kowalchuk, and I'm a clinical professor at Stanford. I'm also co-founder and president of Help Ukraine Group. And together with Astra International Research and Scientific Innovation Committee, led by Dr. Zach Morris, who is with us today and giving us a first lecture, and also with the Sweet Care support, we are launching this year-long project, research methodology course with mentorship to strengthen clinical research capacity in Ukraine. So how it all started, there was definitely a gap and the need in more research and quality improvement in radiation oncology and medical physics in Ukraine. Realizing this, actually, Ruslan Zelinsky proposed having research methodology lectures, one of the conferences in Ukraine. Unfortunately, it never materialized, but this idea was always simmering there. So we saw the interest from also Ministry of Health of Ukraine, Arman Kacharyan. They approached us at ASCO last year. And then finally, we had a really amazing delegation, Ukrainian delegation at Astro last year. And you could see Dr. Morris standing here. I don't know if you could see my pointer. So he is right here, and all these amazing Ukrainians. And so what happened during that delegation meeting with Dr. Morris, we requested to organize this course, and he was really welcoming this idea, and we are really grateful to him and Astra International Research and Development Subcommittee for making this course a reality. Thank you so much. So I will start with few organizational items. This course is in English, and it would be great if you can improve your English together with improving research skills. But if you prefer Ukrainian, you can have your AI subtitling into Ukrainian turned on. The way you do it, please click on Show Captions. So you could see it right here. Show captions, and then you can choose your language, Ukrainian. A few points about the course. The goal is to strengthen clinical research capacity. We have 106 people sign up for this course. We will provide mentorship, mini grants, and travel support for selected research projects. So we applied for a few funding opportunities. And as I mentioned, 106 people registered, among them 61 radiation oncologists, 28 medical physicists, and also other professions. In terms of education, a majority has medical degrees and master degrees. 10 people have PhDs, so we are hoping that potentially they can lead the team research projects if they want to, since they already have research experience. In terms of experience in the field, it's mostly early experience, 0 to 5 years, and virtually all 40 radiotherapy centers registered for this course, so it's very nice to see this participation. In terms of prior clinical research experience, 3 of you already led the projects as lead investigators and 27 as co-investigators, and around 70% did not participate in research projects and would like to learn, and that's why we're actually having this course. And in terms of publications, 55 said that they were not involved in publications in the past, and around 40% never submitted an abstract to a conference. So we hope to improve this metric. It's great also to see that the research is encouraged in your institutions in terms of barriers of doing research. You reported absence of access to IRB. absence of statistical support, and lack of mentorship. So we'll try to match you up with the mentors abroad for your research project. And to obtain the certificate for this course, please take a pre-course test. So I distributed the email this week for you to fill out the very short 10-question test, and QR code is here. So if you have not completed this test, please do so. And this is just to measure the improvement, so do not worry if you don't know the answers to the questions. You hopefully will learn them during this course. A reminder on the format of the course: lectures are once a month on second Wednesday at 8 p.m. Kyiv time. And lectures are approximately 1.5 hours long. So it's 1 hour of lecture, and we also allow 30 minutes for discussion. And attendance will be taken by you answering the Zoom poll questions. So please answer the questions and make sure that your Zoom account is displaying your actual name the way you want it printed on the certificate. And after today's lecture, we'll ask you to propose a research project. You can work on your own, or we actually encourage you to work in a team with either your department or other departments across Ukraine. We will review the proposals and select the strongest one to match with the mentors. Throughout the year of this course, you will hear the lectures, and then you will have some homework to do after the lectures on your research projects. For example, after today's lecture, you propose a research project. We will select strongest projects, match you with the mentors. After the literature review lecture, you'll perform literature review for your selected project. If you have not selected the project and do not want to participate in a research project, that's okay too, just to listen to lectures, and you can do literature review for some example cases that the instructor provides for you. And after data management, study database setup, and statistical analysis lectures, you'll collect the data, analyze the data, and your mentor will be reviewing the data analysis. After scientific writing, publishing peer-reviewed journals, I'll try to write an abstract. And we timed it such that this time is great for Astra abstract submission. The Astra abstract submission is usually at the end of February. And so your mentor will review your abstracts. Hopefully we'll have a lot of abstracts submitted. You can also submit to other conferences, not only Astra, but Istro, OncoHub, Up to Date, and hopefully Rad Onco, UA, or any other conference you would like. But international submissions are strongly encouraged. And so we applied for various funding supports to provide mini grants for you and your teams, and some travel support as well. So we are waiting for the results of these applications. So at the end of the course, the goal is to submit a manuscript. You see here, complete manuscript, and your mentor will help you review the manuscript before submission. Ideally would be international journal, but it can be also national journal. So after today's lecture, we'd ask you to submit the project proposal, and you have 1 week to think about this project. And again, teamwork is really encouraged. So think about it, discuss it with your colleagues, and submit the project. So the due date is May 21st. And we can stay after the lecture to also discuss this if you would like, but hopefully our speaker today will provide you with some great ideas how to start with this. So I will stop sharing the slides and give a podium to Professor Zachary Morris.
Thanks, Natalia. I really appreciate the opportunity to speak with you all today. And thanks, Natalia, for organizing what seems like could be a really helpful course. Happy to take feedback from the group on this, and it's something we can work to adjust and improve on over the course of the year if there are any suggestions. I just wanted to start out on a personal note and just, extend a note of solidarity and support for you all and what you're going through. And I hope there are better days ahead for you all, and for your country. Um, and My topic today, I'll share my screen here and I'll turn my video off because my internet is not great here.
Mhm. And Zach, I can introduce you if you show maybe first slide. I will still read your bio and
Sounds good.
introduce your topic. Yeah, just start sharing. Oh, perfect. So let's start with our first lecture. The topic is formulating a research question. And our speaker is Zach Morris. He is the endowed Paul Harari Professor and Chair of Department of Human Oncology at the University of Wisconsin School of Medicine and Public Health. He completed undergraduate studies at Ripon College and 2 master's degrees at S. Rhodes Scholar at Oxford University before obtaining his MD and PhD from Harvard Medical School. He completed a residency in radiation oncology at the University of Wisconsin, and clinically he specializes in treatment of patients with melanoma and sarcomas, and his research lab has been examining mechanism of therapeutic interaction between radiation therapies and immunotherapies. A prior recipient of NIH Director's Early Independence Award, he has been a co-PI of an NIH Cancer Moonshot Initiative U01 and an NIH PO1. He serves as the co-chair of NCI Radioimmunotherapy Working Group, and he had an amazing career achievements, and we really congratulate you on this, Dr. Morris. So that's quite remarkable, very impressive. And thank you so much for supporting this course and this initiative for Ukraine. And thank you for your kind words of support. In the beginning of this lecture, we are really lucky to have you here. So we are very eager to learn about how to formulate a research question. The podium is yours.
Perfect. Thanks, Natalia. I'll turn my video off, like I said here, but happy to chat at the end more. I do have some disclosures. None of these are particularly relevant, but I do serve on a number of scientific advisory boards and do sponsored research with various pharmaceutical companies. So, the topic of today's lecture is uh, kind of both seemingly very fundamental and basic, which might make it seem potentially boring or unimportant, but I actually would pose that this may be the most important topic of the entire year because none of all of the details of how to do research and how to do it appropriately matter if you don't pick a good research topic that both captivates your imagination and motivates you to conduct and complete the study, and that has importance to the field, to the world, to the application that you're studying. And so I often have to remind myself, even in going through research, to pause and be very thoughtful and purposeful as I think of research questions, because one of the things you'll find as you begin to engage in research is that one question or one study begets many other questions and many other studies and opportunities, and very quickly you'll find that there's more research or questions that you could do than you have hours in the day to actually conduct. And so what you actually choose to do, you want to be very thoughtful and purposeful in, so that you don't end up buried in the details of some project that you really don't particularly care about, or that you don't find to be important. So on that note, there's many justifications for research. Discovery and scientific advancement takes place through research. research and science is something that is pure in its ideals to make advances in knowledge, and that can be very refreshing in the setting of all of the other forms of information that we're inundated with and propaganda and whatnot in today's society. Research is a very kind of pure endeavor, and I find it personally refreshing to take place in trying to advance knowledge. While it's not perfect, it's always well intended. It's a critical not only for discovery, but also for translating scientific advances to clinic. And this is where, in our professions, we stand on the shoulder of previous giants who have gotten us to the point where we are. And the future will certainly depend on the advances that we make through research in terms of how we are going to improve the treatment of our patients. And that is at the core then of clinical progress. And this is the way through research that we have and hopefully will continue to see improvements in our care for patients. It's also important in our own day-to-day operations and our working lives, particularly in radiation oncology, where what we deliver is potentially dangerous, potentially harmful if not done carefully. And we should never take for granted that we are doing things the right way. Quality assurance is really integral to the safe operation of any radiation oncology clinic. And that in and of itself is sort of a form of internal research to make sure that the outcomes we are seeing are what we expect and what are reported elsewhere. Patient safety and patient quality of life are important forms of research. There can be a tendency sometimes to focus on survival outcomes or disease control, but there are many other purposes that we all know clinically that we do treatment for palliative intent and to improve patient quality of life. But those are often understudied areas and areas that are very accessible to us doing our own research and to improving our health systems. And so there's many potential inefficiencies in health systems, and by studying different ways to deliver care, we can improve the systems of care overall. And so each of these are potential areas for engagement as a radiation oncologist in potentially any environment. Many of these forms of studies don't really take much more than a motivated individual in terms of resources. There's other reasons to consider doing research as well. Career development in many cases. Publications from research can lead to recognition and career development and awards and opportunities. It can also be a critical component, and I can personally say for me it has been, of our own wellness and resilience. I know that you all are well aware treating cancer patients is a challenge on us as individuals, and it's very clear, I think, to all of us in the clinic each day that the treatment options we have are not ideal. They're not where we would like to be. They're the best we have, and we do our best to offer them with utmost care and safety for our patients. But it can take a toll on a person, on a provider, to see patients passing or undergoing side effects, suffering from side effects that we wish we didn't have. And this can be a really nice outlet for us to take the opportunity to try to improve our field. It's also been, for me, a way to develop a professional network beyond my local environment, to develop professional as well as what ultimately in many cases become collegial friendships or professional friendships where we reconnect with folks at ASTRO or ESTRO or other society over time, and can really be a fun part of our career path. For your own operations, depending on the health system you're in, offering research can also be important to the bottom line, to supporting your institution. Places that have research underway often have a greater reputation for quality and often can offer clinical trials or clinical opportunities to patients that aren't available elsewhere. And so this can be a means for recruiting more patients to your center. And it can also be a means for bringing in funding That can be through third parties, societies, um, philanthropy, and also potentially through government sources or non-governmental organizations that provide support for research or reimbursement. So the first question here, we try to make this interactive, is why do you do research? This is an app called Slido that I've used. It's a free app, and so if you haven't ever used it before, it can sometimes be nice. You can use this, and it's free text, and it'll just develop a word cloud. But it's appreciate if you could, if you have a ability, type in some reasons, and we'll see what you all are motivated by. So we're getting a number of responses coming in. Appreciate that. So practice improvement, that's a great one. We talked about a bit how this can be an internal form opportunity to look at our own practices. It brings life to the routine work, which is also, I find that absolutely to be the case for me. Pushing progress, keeping us up with modern trials and trends, because as we'll talk about in the next lecture, it's very important when you're doing research to be aware of what's out there and what's been done previously. This is great. And then this one of the nice features of this app is that it'll save this, and so we can go back to this word cloud, Natalia, and potentially something we can also re-poll the audience maybe later in the year to see what folks feel about. But this is a way also that we can use, and I've done this before, where we generate these types of input, and then this can make a nice addition to a paper or that, because even putting together a course like this can be something that's a source of research in terms of how do we learn and how can we learn better and engage. And so thank you all for participating in that poll. And just given, looks like one more person is typing, so I give them a couple seconds here to.
I like this. Research brings life to routine work. That's really
Yeah.
true. Yeah.
Okay. So to get started, one of the key aspects of almost any research project is that we need to often build a team. It depends on the project, of course, and it depends on what you're proposing. But some examples of the type of collaborators or teams that you might want to bring together would include your clinical collaborators. And so if this is a study where you need access to patients, it often is critical to partner with the specialty or someone in the specialty who sees those patients or who controls kind of what they're going on to. In often case, for example, here in settings of metastatic disease, much of the time our medical oncology colleagues will be primarily seeing those patients and following them. And it would be hard for us to run a new study on patients with metastatic disease without engaging with those medical oncologists. It's not as if those patients would just show up at our door. And then also kind of what ancillary studies do you need access to? And so if you need pathology results, or if you need specific pathology questions to be addressed, that'll be important. And also if you need access to imaging, if you're going to be monitoring response to a given treatment, for example, by like RECIST criteria, then it's often critical to have buy-in from your radiologists. As we'll come to, we can often do our own biostatistics on a basic level, but for more advanced studies, it's really often very important and to engage with a biostatistics expert. And I will say, when you go to apply, for example, for a grant, it's often impossible to convince a grant review panel that you personally have all the expertise to do both the clinical treatment and the biostatistics. And so you'll often need, from a grantsmanship standpoint, to engage with those biostatistic experts or informatics experts, depending on what you're proposing. You'll also need staff coordinators, often to gather and maintain data or maintain the database. In some cases, we do projects where that is done by trainees, if it's a resident or a medical student-led project. But for the majority of our studies where we're collecting data, we're relying on staff or nurses or medical assistants or professional research coordinators to help out with that. There often needs to be a system for data management. It can be something that you do or your institution provides, but that's something that has to be addressed. And then one of the points I would make, which I think is, sometimes obvious, but sometimes overlooked, and it can cause hard feelings down the line, is once you develop a team, to have at least one kind of initial meeting where you level set and talk with everyone about what the different roles are and expectations are, how much funding support there is. So if you're expecting to, pay for a certain amount of their time or their effort, it's important to let them know exactly what that is to make sure that that feels like a fair compensation for the time they're putting in. And also, even at this point, I will often discuss what I anticipate kind of the authorship roles will be. Who's going to be first author? Who's going to be last? Because this often helps people to not feel later on like they were cheated out of some role, or that they know what kind of effort they should be putting in based on the role that they have. Some more thoughts on building this type of infrastructure. Mentorship is really critical, I think, to success in research. And that can come in many forms. That can be from more senior folks at your own institution. It can be across institutions. It can be through professional societies like this. There are a number of folks on our Astro International Committee who are very interested in being mentors and being mentors for research. So if you don't have local mentors, you can often find mentors at a distance at other institutions, and professional societies like Astro and Estro are great for that. Here, and I think at many places, we have what we call disease-oriented teams for our clinical trials group, and this is infrastructure that ensures that we have expertise and understanding of the state of a given treatment for a disease. I think this is particularly important if, for those of you that are maybe medical physicists or PhD trained, where you may not have as much insight into what is the current standard of treatment for these patients and how many patients are there with this type of condition or disease and stage of disease. That's where you often need a disease-oriented clinical team to help guide, to understand what's feasible and what's kind of ethical to do in clinical practice. For our physicians, it's often, if it's our own area of expertise, then we're often serving on these teams. Protocol writing, sometimes, many times that comes down to the individual leading the project. But there are services that will help with that. So if you've never written a protocol before, you can often at least get an example. If you've never written a clinical trial protocol and you need an example, I'm happy to share some. I think many people would be. But it's the first one is often the most challenging. But there are services, if you get funding, who will help write a protocol for you, and that can expedite the whole process. If you're doing clinical research that involves industry or other funding mechanisms, oftentimes you'll need to negotiate what a clinical trial agreement. This will lay out the arrangements for who can publish the data, for example, who owns the data, who's paying for it, what is the budget for that, and you may have support for that or maybe not, but at many places this is done through coordination with the institution and often with the legal group at the institution who can help with contracting and clinical trial agreements. But that's something that we generally do at a time point kind of before we finalize the clinical protocol, because you need to understand what the budget is and what's feasible before you can really finalize the clinical study itself. Institutional review boards are really essential to ethical research, particularly if you're doing patient-oriented research, patient-specific research. For some forms of research, certain quality assurance is that they may be IRB exempt, or certain forms of retrospective studies. But for almost all interventional studies, and even database type studies where there's a risk for at least a loss of privacy, then it's important to have some form of an IRB review. And if you have it at your own institution, that's great. There are also IRBs that will support other institutions. And so that's, again, something that you can outsource if needed. Once you are through that, you have a protocol and IRB review, you're ready to go often, but I find that often there's a bit more delay there than I would like, and it's something to be aware of. Just that as you're kind of ready to initiate research, that's another time point where it's often critical to bring together your team and refresh, because while you may be leading this research and it's very fresh in your mind, it may not be fresh in the minds of your collaborators, your staff, your nursing team, your coordinators. You want to kind of bring this back and say, okay, now we're actually going to be doing this. Oftentimes you've gone around, gotten everyone's input, but it's been 3 or 6 months ago, and they don't remember what they were supposed to do. And so for efficiency, as you begin to open a study, I would often recommend bringing your team back together and kind of refreshing their memories. We mentioned already kind of the research staff and database record keeping. Another component of research to consider is, like, do you need, if it's clinical research, any specific labs or core facilities to do analyses on, like, blood or biopsies or other specimens? And these are oftentimes, I find, where we are looking to collaborate. And this is definitely something where, for example, my lab receives specimens from clinical trials around the country, sometimes around the globe, to do analyses on. We don't necessarily do it for free, but if you have a funded study, you don't need to have, and oftentimes you should not expect to have, all the resources at one place to do all aspects of that. But you can develop collaborations that can allow you to complete those. So this is just to point out that I think with these types of studies, almost all of us feel a limitation on resources at some point. There's very rarely an institution that has everything it needs, all the people under one roof to do this, or one department at least. Often we're working across departments and across institutions, or with industry, or with other funders. And so collaboration is the name of the game here. But certainly there are certain settings and certain countries where resources are even more limited, and then collaboration and mentorship becomes even, I think, more critical. And one of the things I wanted to mention, because it sounded like from the statistics that Natalia showed that many of you haven't done a whole lot of research before, is the opportunity to engage with mentors. And so Astro started the Astro Mentorship Program, and this QR code here will take you to that website. And I will say that you may be sitting there thinking it's hard to find a mentor. This is my second year as the chair for the Astro International Scientific Innovation and Research Committee, and we have about 30 members of that subcommittee. It's a fairly big group, and it's fairly active. And as far as I know, every one of them signed up to be a mentor in this program. And so far, only one, to my knowledge, has actually been requested to serve as a mentor. So there's actually a lot of people out there wanting to be mentors who haven't found a match. And so you can go on here, and there's opportunities to pick, like, global health, or pick what your interest is and find a mentor. So please take advantage of this if you want to. The other thing to consider, I think, as all of us think about the limitations of our resources, is that when you begin to conceptualize a project or a question, we always have to manage the scope of what we're going to do. There's always limits in terms of, like, am I going to do this study? Can I get 1,000 patients? Well, I need a lot of funding to do that. Can I get 10 patients? Well, then is that enough to design the study in the way that I want? And so you really need to understand kind of the scope of what you can do personally, your own bandwidth and your funding and the patients, to establish a question. So while this topic that I started out on here is defining a research question, you can't ask a question in the absence of thinking about your resources and your limitations and bandwidth, because we could all ask very interesting questions. If we could accrue 10,000 patients to this study, we could, prove something very minute, but we know that that's not possible or reasonable to be achieved. And so we have to formulate questions that are factoring in what's achievable. Another shameless promotion here for my own subcommittee. That's often as one begins to think about, what are their own resources? What are the resources out there? There's a lot that you may not know of in terms of what grants are out there, what funding mechanisms are out there, and how to formulate a question that kind of takes into account feasibility in terms of patients and takes into account the current standards of care, the local standards of care. And this is a complex process that many of us, over time, develop experience with and can help provide advice. But the first time you do it, it can be quite daunting. So again, the ASTRO subcommittee that I lead, the International Scientific Innovation Research Committee, one of the things we launched last year was a research consult program. And so this is an opportunity that would pair really well with this course. Is if you have a research project and you need some input on, or if you're writing an abstract and you need somebody to review that abstract and provide some feedback and edits. This is a website. You can use this QR code to link to, and the 30 odd members of that committee are signed up to field responses here and provide input. And if they don't have the expertise, they'll bring it back to one of our monthly committee meetings and invite you to present, and we will all give you feedback on that. And we've had a couple of presentations from some individuals across different countries in Africa present even on their PhD thesis projects. But honestly, I think we've only had 2 or 3 people submit a request for this type of input. And so, again, another example of it may be hard to find input, but there are resources like this out there that I think just a lot of people aren't aware of. So another time to kind of hopefully wake everyone back up a bit. Sorry, I tend to drone on a lot and talk a lot. What are the barriers that limit your ability and your interest in doing research? What are the things that are barriers for you? Time and resources. That's probably going to be like the number one. We could all just like give that a thumbs up. Experience, yeah. First step. So those two, I think that's very common that we all experience that at some point. And for those who find that it's the lack of experience and the making the first step, I would encourage you to take that risk, take that first step and try it, because it'll always be hard the first time, and it only gets easier afterwards. But take a chance and go for it. You'll learn along the way. You may fail a couple times, but you'll definitely learn. And the second, third, fourth time gets so much easier. And take advantage, maybe for those of you in that position, of some of those resources I mentioned for mentorship. The lack of time and resources, the time part I can't solve. We all face that. The resources, sometimes finding mentorship or reaching out to groups like we mentioned may help make you aware of different funding mechanisms that you could pursue. But those are always going to be limits. The lack of knowledge, hopefully this course will help with that a bit. The financial support, I hear you. That's a barrier for all of us. Procrastination, that's I can't. All I can say is I agree. We all feel you. Um, Language, that might be something where this course also hopefully can help, Natalia and other folks who might be able to help bridge that. It's something that the various committees are working on as well with interest. We're trying to do things like help develop translations of some of the various guidelines and that. So um, you can bring those as concerns. The error alerts, my heart goes out to you all. I hope that that will be over in a short time with a improvement in the situation. Don't be afraid of being incompetent. We all feel that way, that kind of imposter syndrome or the lack of courage. There's no wrong way to go about trying to do research. It's our own way to try to make an improvement. And the good thing about research is that you're studying something that nobody knows and nobody has ever solved because it's a question or a problem that we've identified. And so, uh, if you don't solve it, or if you, so-called fail, you're one of all of the rest of us because no one else has solved it either. So, there's no risk per se. The bigger risk, I'd say, would be not taking a shot at it. Okay. Well, thanks for uh, participating in that poll. So let's assume that maybe through this course or otherwise, you're going to take a shot at doing some research. How do we get started? As I mentioned in the beginning, I think one of the key initial steps is to pick something that you find captivating. You're probably, whatever you think it's going to take you to finish this project, you should probably double it. It always takes longer. And so you're going to be working on this. And by the time you're done with it, you're going to be like, oh, wow, that took a lot. And so you want it to at least be something that you find of importance and interest. Very rarely is anyone forced to do research on a topic. It's often, almost always, a choice or something you pick. And so this is one of those things that you have agency over. Find something that you care about, that you think is important, that needs to be done better or studied more, and lead that based on your own personal interests, I would say. Don't factor in so much other things. And I would often advise folks, sometimes a research project comes to you and you're not interested, but it seems like somebody else is interested in having you do it. Those are the types I might consider passing on, unless it's like your boss and it's part of your job. But that aside, uh, you really want to personally identify with what you're going to do here. And once you have kind of found that area or that discipline, then I think a good way to identify what is important is to try to think of what is a problem. What is something that needs to be done better? And you need to take that at the right level. Like, yes, cancer is a problem, but that's too big to study. Conversely, finding the vein for IV access on this one person is a problem. That's too small to study, right? You got to find something that is accessible to research that can be studied, and something that you think is important, but also feasible to address. And once you've identified that problem, what you want to do is formulate that in the form of a research question. So ask a question directly related to that problem. So, for example, uh, you could think of a prospective type of study, um, prostate cancer, metastatic disease, limited survival. Can we improve on the treatment of prostate cancer with drug X? And even there, we might need to be more specific with the stage and situation. But that's kind of how you would move from a problem to a question. And what I would say is this seems very simple. And again, this whole lecture is very simple. You're going to get much more technical lectures for the rest of the year in this course. But this is the key part of any of this. When I write a clinical protocol or a grant, I will say that I spend the most time on my question and then my specific aims or how I'm going to address that question compared to like the other 80 pages of material that I write on there. Because if the question and the problem are not just what I want, none of the other part matters, and none of the other part is going to review well or get funded. So this is the most critical step of all this. There's a number of kind of acronyms for what makes a strong research question. I put a couple of them here. These are, somewhat commonsensical, but I think helpful nevertheless. So there's the SMART acronym, which stands for specific, measurable, achievable, realistic, and considers time constraints. So specific, you want to be very specific in your question, talking about something that you understand and that is something that you can address. Measurable, you want the something that can be tested. So can it be improved? How will you know if you addressed it, or how will you know if your project is achieving what you said? And then it needs to be achievable. It needs to be a question that can be addressed in the timelines that you have available with the resources you have available. And that is also kind of speaking to the realistic aspect here and the time constraints. Another acronym here, I put them on the same page because they are overlapping a bit. I don't want to be too redundant, but the FINER acronym, feasible, interesting. I think those speak to themselves. We covered that a bit already. Novel, in addition to what we've mentioned, it should be something that hasn't already been done or that you're not aware is being done elsewhere. I wouldn't get too hung up on that, though. I wouldn't get too worried about, like, is somebody already doing this, or will they scoop me? Will they publish this before? There's almost always room for more than one study on a given topic to validate one another or to do it in a different population. And so that one I find not to be an absolute. If you have a question that you think hasn't been addressed in your patient population or your region, there's still often value in doing that study. Is it ethical? So this is, something where you need to factor in, can you conduct this? Is it putting patients at risk? Is there a reasonable benefit? Research needs to be done with a strong concern for ethics so that the patient's rights are being protected and that they're not being taken advantage of or put at unnecessary risk, and that you're not withholding something that we know is good or beneficial in the interest of testing something that is unknown. And it needs to be relevant, and we've spoken a bit about that as well. Another of these type of acronyms that's a bit more proximal to clinical types of investigation is the PICO framework. This is to identify, once you have a question, more specifically to drill down and look at what is the patient, the population, and the problem. And I would say and rather than or there, but what are the characteristics of these patients, what stage, what age, all of the demographic features that you need to consider, and what is the condition or the disease that you're studying. What are you going to do here? Is there an intervention? Is there an exposure? Or are you just monitoring or looking back in time? That will often factor into what type of study you're going to do. Are you doing this as an intervention that you're giving, in which case it may be prospective, or is it an exposure that they got in the past, and so it's going to be retrospective, and that will speak to then the type of study you're going to do. How are you going to compare the group? So is this going to be a randomized study where you're looking at one thing versus another? Is it a cohort that has a given outcome and you're comparing to those who don't have that outcome? Are you comparing those who were exposed to something versus those that weren't? These are the types of questions that will help you to guide what type of clinical study is most appropriate. And then what is the outcome? And that's really key. That outcome needs to address or answer the question that you pose. And it may not initially. So this is where this process is not like you come up with a question and that's it. That's the one you're going to stick with and go with. Rather, you think of a question, you begin to apply these smarter, finer PICO frameworks. You go back and say, well, I can't really design a study to answer that question. I need to adjust my question. And this happens over and over until you land on a question and a question that can be addressed with a study design. So again, sorry for being long-winded. I want to wake you back up here. Which of the following describes the PICO criteria? A, B, or C? And thanks, Natalia, for putting together the Zoom poll. Like you with the slide, I have no experience with Zoom polls, so.
But I really like the Slido. We should use that more. But that was really nice to see answers and the word clouds. It was fun.
One of the nice things about it is that it's a add-on in PowerPoint, so you just make it in your PowerPoint slides. It shows up on the toolbar at the top of PowerPoint when you have it on your computer.
Oh, that's awesome. I should try it out. So yeah, I would like to encourage everyone to answer the questions. That's how we take attendance. So please answer. Будь ласка, відповідайте на запитання. Ми так беремо присутність. Zach, you will learn some Ukrainian here.
I was just thinking I need to. How do you say research question in Ukrainian?
Хтось може допомогти? Research question.
Тема дослідження.
Тема дослідження. Дослідницьке питання. Угу.
That's too fast. You gotta slow it down.
Дослідницьке питання.
Дослідницьке питання.
Very good. Excellent. Awesome. So I am ending the poll. I see 81% answered and I'm sharing the result. So we have majority 65% answering B. Do you want to comment?
Yeah, perfect. So that's exactly right. Some of these are very close here, but you want to think about the patient's, the intervention, what you're going to be doing, what your comparator group is, and what the outcome will be. All of these touch on things that are important, I will say, but none of you, I would say, were wrong overall, because thinking about the conclusions is still important. Thinking about the collaborators and being comprehensive are all still good ideas, but the PICO criteria is B. Okay. Question 2. I'll take another poll here. So you're interested in studying the impact of induction chemotherapy on outcomes in locally advanced cervical cancer compared to standard upfront definitive chemoradiation. On a chart review, you realize only 4 cervical cancer patients in the past 10 years have been treated with induction chemo at your hospital. Which of the finer criteria is lacking?
Yeah, we'll wait until 80% answers, but so far answering very well. Great work. Okay, I'm ending the poll and sharing the results. So majority 67% answered A, feasibility. або здійсненість. Do you want to
Yeah,
comment?
I think that's right here. So this is something where it's very unlikely with 4 patients that you're going to be powered to detect the answer to this question, which is the impact on locally advanced cervical cancer. So you wouldn't want to set yourself up for failure if you go into this with what seems like a clear understanding that you're going to have a non-significant outcome. You basically are trying to tackle a problem that you can't possibly study with this level. So this is where working with a biostatistician can help, and you can understand how much power you do a power calculation, how much power you need to be able to have a chance of proving that one thing is different than another. But very likely in this situation, given the variation from patient to patient, almost certainly 4 patients would not be possible to address this. And so it's not feasible. You could debate whether it's interesting. It's potentially novel. You might say it's unethical. People would say if you do a study that's not feasible, then it is unethical because you're wasting patients' time and you're wasting resources on this that could have been done for something else. But feasibility is probably the key correct answer here. And is it relevant? Well, that's again more of an opinion, I think, in this case, but for the field, it could be relevant. So, okay. So once you have developed a research question, the next step that you want to do is to formulate a hypothesis. And sometimes this can be rapid, sometimes it can take quite a bit of time. Once you've gotten an initial question, you often want to do some preliminary investigation. And this is going to be the subject of next lecture where we talk about like literature review. At the very least, you want to understand the field and where things stand currently as it relates to that question and formulate a hypothesis. And what I would also advise you to do is to really spend a lot of time in that process of making a hypothesis. You want to make a hypothesis that you really believe is the likely answer to your question. And again, that will make it important. That will also allow you to test something that is meaningful. If you formulate a hypothesis that is very unlikely to be true, you're likely wasting your time. Define the variables that you need to study, formulate that hypothesis, revise that, make sure it's specific, make sure it's clear, make sure it is actually addressing your question so that your question is answered by that hypothesis. You should have a question, and then the hypothesis is your answer to that, which you are going to test. And this process of review and refine is so critical. You formulate the question, you think about it more, you develop a hypothesis, you go back and you readdress it, and this should take a bit of time. It's something that could be done very quickly, but you would do so at your peril. I would not think of this as a quick process because this is where a mistake or mishap here is going to doom the rest of your processing or waste a lot of time. Test the feasibility. So think about, is it possible to address this by saying, what is your expected effect and how much data, how many patients, how many outcomes do you need in order to have a chance to feasibly address this? And then based on the answer to that, you might have to go back and restate your hypothesis or restate your question even. And then once you have a hypothesis, you want to think about alternatives because this is where you're going to be testing basically your hypothesis. That's what your statistics is going to be built around, that you can work with a biostatistician or do your own to understand what it's going to take to test this and to determine if your study has a chance of doing so, and what are the chances that it will, if you find significance versus what are the chances that it won't. So you want to, as you're thinking about that hypothesis, you're going to then begin formulating the design of your study. And that's where you want to understand, do your aims or your outcomes of your study actually test your hypothesis? Is the answer that you're going to come up with from your study going to either prove or refute your hypothesis? If not, keep revising, keep working at that until it does. Is there a better way? So you don't want to, you may be able to address a hypothesis, but if your reviewers say, well, this really should have been studied in a different way, like you try to address it using a certain method, but that method of, look, so say it's like you're studying something in blood and you're using a Western blot to look at proteins expressed there. But that assay is not felt to be a very good assay to look at those proteins. Instead, maybe you should look at flow cytometry because you need to know not only the proteins are there, but what cell they're on, something like that. You want to make sure that you're using what is a agreed on approach to that is usable and useful for testing this. You don't want to be using methods or an approach that others are going to critique later, because you could conduct the whole study and then have someone critique you, a reviewer for your paper or your grant or your abstract, say, well, yeah, that's an interesting question, but you're doing it all the wrong way. So you want to head that off early. And I mentioned already kind of the statistical considerations. And just really want to emphasize this last point. This does not typically happen in the first 1, 2, 3, 4 iterations for me. I often write a research question, write a hypothesis, begin writing my aims, go back and change the question slightly so it's something that is better addressed or can be revise my hypothesis so it's something that I can actually test with the methods and population or techniques I have available. And also with it changes when I get funding or don't get funding, that I look at the resources I have and it's something that incorporates all the things we've talked about. And then just briefly want to talk about on the clinical setting, what are those types of approaches that you can apply? So if this is a clinical type of study, this is a chart to consider what is the right type of clinical trial or clinical study design. Are you exposing patients to something in the study? Are you going to do something or intervene? If yes, then it's an experimental study. If not, it's going to be an observational study. That's the first kind of dichotomous breakdown here. If you're giving something, it's an experimental study. Are you randomizing patients to get that, or is it non-randomized? Then it's a randomized control study or a non-randomized trial. And there's various reasons for either of them. If you can randomize, that removes some of the potential bias and patient selection biases in a given study. But you need to consider what's ethical, and you should not be withholding something that is known to benefit someone. That if this is a study of something like that, then that might be where you need to do a non-randomized type of approach. Still can be studied, it's just a different type of study. If you're not exposing or doing an intervention, then it's an observational study. What is your comparison group? If you don't have a comparator, then you're just kind of doing a description. So we're going to do this, or we're going to observe this thing and report on it. We're going to maybe report on what is the makeup of the populations in terms of gender, age, and better just understand the disease. It's just a descriptive study that can be valuable. If it's something we really don't understand, that's the first step in beginning to understand something. If you have a comparator group, then it's more of an analytic. It's not descriptive. And how are you comparing that? So are you looking at trying to understand a past exposure, a current exposure, and follow those patients for an outcome? That would be a cohort study. So they're going to be exposed to radiation now or not? And you're going to follow them over the next X number of years to see if they develop this side effect. So that's more of a cohort study. Conversely, do they have an outcome? So you are looking at all the patients who have a certain toxicity. This is an outcome. And you're looking backwards in time to understand, were they exposed to radiation or not? This would be more of a case control study where you get folks that have the outcome versus those that don't, and you look at a prior exposure as to whether it's associated with. And then there are cases that involve or studies that involve exposure and outcomes simultaneously. It's more of a cross-sectional type of population type study. So plenty of opportunities to think more about this, but the key first step here is kind of, are you doing an intervention or not? And then if not, do you have a comparison group or not? If there isn't, it's a descriptor study. It's quite easy. If you do, then that's a point where you can sometimes figure out what exactly the study design should be on your own. For those of you that are kind of thinking about this for the first time, this might be a bit confusing. This would be a great opportunity to submit like a research consult question to that Astro and get some input from folks who do various clinical trials or studies as to what might be the most appropriate study design for that question and for the resources and population that you have. Okay. And I know I've said it, but I want to hit this point home. It's an iterative process, meaning that we work on this process over time. Oftentimes, I'll come through the hypothesis and into my study design and think, you know what, I can't actually do this type of thing as a cohort study or as an intervention. I need to adjust my study design based on feasibility or funding or other. And that makes me then have to go back and reformulate my hypothesis so that I can actually test it, which means I often have to reformulate my research question slightly. So you should expect as you go through this that you're continuing kind of going back and double checking that with each new piece that you can complete, that your design and question are appropriate. So just wanted to kind of give some more concrete examples and also just to show some examples from my own background. It's not to say that what I did was right or wrong, but just to illustrate that you can often ask a question or do research with relatively limited time and resources. So this was my first clinical type of study that I did. I started this my first year out of medical school. I didn't actually do any clinical research in medical school. I did a PhD, but it was all basic science and kind of preclinical research. And coming into residency, it was something that I kind of regretted. I wish that I had gotten some more experience in it. So as an intern, I had 1 month of elective, and I thought I would try to do a clinical study. So I worked with Dr. Stuart Tsuji. He was at the University of Hawaii. That's where I did my intern year. Kind of here we do 1 year of internship and then radiation oncology residency for 4 years after. So in my 1 month there, I collected data on patients with colorectal cancer who were treated in Hawaii. And honestly, I was just trying to look for potential correlates of response. So this is technically not something that you should do from a statistical standpoint. You should formulate a hypothesis about something specific and, test that one thing. Well, I didn't kind of have a specific thing that I thought was going to correlate with outcomes, and I just wanted to get started. So I looked at all of the colorectal cancer patients that had been treated with radiation there for early stage disease. And we built out a data set, and I looked at the medications that they were on during the time they were getting treatment, and then began to look for associations of local control and survival. Now, that is not statistically valid as an approach. That's what we would call a fishing expedition. You're just looking for what's significant, but it's still something you can do. In this project, where I would say that was is I had formulated a problem. I didn't yet quite have a question, and I was gathering information. This is sort of in the information gathering stage. So I began to build out a data set to understand whether there was any associations. And that's okay, as long as you don't try to then lie or misstate and say that what you found was this you pulled this hypothesis and it was significant. So what I did after that is we found that ACE inhibitors were associated with improved local control in that patient population. And that took, a couple of weeks to gather that data and to run some very brief statistics, just going through charts. Then when I moved to Wisconsin here as a resident, it gave me now a hypothesis, which was I hypothesized that ACE or ARB inhibitors would affect local control for the patients getting radiation. And now I had an independent data set that I could build from a completely different patient population and actually test that. And so that's what I did here. But we published both. We published kind of the initial test cohort and then a separately analyzed uh, validation cohort. And that, I believe, is appropriate. And it's an okay way. If you don't have sort of an initial question, you can do a fishing expedition, look for what's interesting, but then you need to validate that in an independent data set that you build out and test that actual hypothesis. So that's the story here. And it didn't take that much time. It was just me and an Excel spreadsheet and, our medical records going through medicines and treatments. This was my second clinical type study that I did. This happened when I was a first year resident here at Wisconsin, and I went to a tumor board, and somebody uh, presented a patient who had uh, two non-small cell lung cancer nodules, quite small, about 1 centimeter each, but on opposite lungs, one in the right lung, one in the left lung. And by the book, those patients are metastatic disease if they have the same histology. They're both adenos. If you have a squame and an adeno, then there'd be two primaries. But by the staging system, those were considered metastatic. But, for patients who have a common exposure like tobacco use, it makes sense that some of them are actually going to develop two primaries at the same time, and it's not truly like a hematogenic spread of disease. And so we hypothesized that these patients who have contralateral disease from lung cancer, no disease outside of the chest, and no nodal disease might have a better outcome than patients with, distant metastatic disease, but also maybe even than stage 3 patients with nodal disease. And so this required a lot of patience. And so we worked with what's called the SEER database. The SEER database is a um, publicly available data set uh, in the US here. But there are many publicly available type data sets like this that one can access, and you can get kind of survival outcomes based on stage of disease. And we were able to assess this question. And we found out, in fact, that it was the case that like M1A patients in the stage 7 staging system did have better survival outcomes probably because some of them are not actually metastatic, but have two primaries. And it influences kind of how we treat these patients in that, we give them the benefit of the doubt and treat them as if they have potentially curative disease, even though they have two separate tumor nodules. Another example is to study ourselves. And so this was a study that I partnered with a co-resident of mine on. I did not lead this, but Steve Rosenberg, he's now at Moffitt, got a number of publications just studying readability of material for patients, educational material. And this is something you could do in your own country, in your own site, to understand kind of, are the patients getting the message that we're putting out to them? Public health systems and other groups might be putting out. And there's some fairly simple internet systems that will take anything you put in there text-wise and give it a readability score. And oftentimes medical literature is overly complicated and not well understood by patients. As physicians, we may assume it's easily understood, but in fact, patients who have no medical background may be very confused by what it's actually communicating. And so this is an opportunity to take a look at, your own institutional or government or other groups' literature and patient type literature and understand, is it actually understandable to patients? Is it written at a level that they can understand? And then a final example here of the type of study that I think is quite accessible for someone who's interested in kind of a first time. This is something we did through an ASTRO committee initially. We were talking on the International Research Committee at the time about what do different groups use to treat radiation toxicities. Like here in Wisconsin, we're the dairy state. And a lot of our women with breast cancer use what's called udder balm. I don't know if you ever heard of it, but it's a ointment that they put on cows when they get irritated from the milking of cows. And I don't know that a lot of other states use that, but it's kind of a home remedy for skin toxicity from breast radiation. And there's many examples of that, I think, around the world of like, what is something that Ukrainians use for any like skin or mucositis or other thing. And we wanted to understand kind of what the variation is and is there any data behind any of those. And so we did just a survey of radiation oncologists to understand what alternative medicines, local ointments, etc., their patients were using for radiation toxicities. And it was actually interesting that it's something that shed light on some various local remedies. But these are the type of survey opportunities where we can kind of study ourselves, study our practice, study our colleagues, and get a nice publication out of it. So, and then there's also the potential for more interventional type studies, and this is one where, as radiation oncologists, one of the nice things that we have control over is the radiation beam and what we treat. And so this was a study where patients were getting standard of care with an immune checkpoint inhibitor, anti-PD-1 therapy for lung cancer, and we randomized them to get radiation to one site or to all of the sites of disease with oligometastatic settings. Sorry, we did not randomize them. We just delivered, in this case, to all sites of disease. Very small number of patients, but it was kind of a proof of concept at the time that this could be done. There's subsequently, I think, interest in doing randomized versions of this, but um, these are the types of questions with radiation where we can ask, without necessarily involving a drug company, a very specific interventional type of question. So those are just some examples to maybe give some food for thought. Here's another question now for an audience poll. So your colleague approaches you and asks for assistance in reviewing their research, which reads a retrospective review of the association of socioeconomic factors with overall survival in breast cancer in a resource-limited setting. What areas would you suggest need additional elaboration? So they need to talk more about the patient population, the comparison, the study, the patient population and the comparison, or all the above.
Thank you for sharing all those studies and your experience in first paper, and was published in Cancer. That's amazing.
Yeah.
Good job. That's impressive. Okay, so I am ending the poll and sharing results. So most people said all of the above.
Yeah, I would agree. I think this is a great start to an important question, but socioeconomic factors, that is very broad. Um, Breast cancer is very broad. The difference between early stage versus metastatic patients there is, going to have more impact maybe than almost anything else. And even resource limited settings, I think is quite broad. And so all of these, I would say, need a bit more clarification. A good start, nevertheless. And so the study type here, we didn't, I guess we didn't have to say the retrospective review, although I would argue that E is not wrong either, because we could certainly talk more a bit about that type of review. Okay. Which of the following is the best research question?
Okay, we have 81% answering. I'm ending the poll, sharing results, and majority 56% answered B. Also, there are some answers 32% C. Do you mind commenting?
Yeah, so I think this is a bit subjective, but B maybe a bit more specific. It's asking something that you can certainly study in terms of does the staging scan lead to, and you have a clear outcome here. So that I think in some ways makes it more uh, uh, effective as a question than the others. I will say though that it's a question that still could be refined more. It's sort of a yes or no, and you might try to quantify that because ultimately that could come down to a dichotomous variable. You might get more power out of combining B and C by saying, putting a metric there, um, what patient percentage of patients need to be screened in order to impact, or what would be the level of impact that we're expecting to achieve here. But the change in the staging, I think, is likely to be seen here, and then that would likely change management. So any subjective question, there's room for variability, and you should always expect that no matter how great you write your research question, someone else will provide some critique or thought on it, and that's just part of the scientific process to like circulate it, get input from others, and have a thick skin so that you don't take any criticisms as personal, but just as a way to continually refine, and you can take advice or not from what you hear. Okay, so the final thing that we want to do here, and this is something that can continue beyond the course of this, because I do have to actually wrap up here in a few minutes to jump to another meeting. But the homework, I believe, if I'm not mistaken, Natalia, is to begin formulating your own research question, potentially as a group or a team. But I thought we could begin to state some of those now, and you can continue to do this. And so as we see any of these pop up, we can just begin to comment on, those finer and smart criteria. You want to be specific, you want to be realistic, achievable, feasible, novel, important, relevant, ethical. And then you also want to think about those PICO criteria or PICO criteria. Include some information about the patient or the problem, the intervention or what you're studying, the comparison, and the outcome. And so I think this will kind of lead into homework that can happen over the coming month. And we're happy to kind of hopefully kickstart this year-long experience and lecture series with this finishing point here. Natalia, anything you want to add to this, or?
No, that's been really great lecture. So I'm curious what people will write up here on this question. When do you need to leave? 11:30?
Yeah, your time. Yep.
2 minutes. We can stay after this and discuss with Ukrainians. Maybe in Ukraine will be easier for them after you.
Yeah.
Yeah. But their homework is I'll be sending out the form, and they need to think about the research question and maybe on their own or as a team, and then submit the research proposal. And then we will review as a committee and then select the strongest proposals, match with the mentors, and then continue on throughout this year to work on these research projects.